We would like to acknowledge the Ngunnawal people as the traditional owners of the lands on which the Street Theatre stands and where we live and create. We recognise their continuing connection to land, waters and culture, and pay our respects to their elders past, present and future.
Good evening, everyone. Hello. Thank you. I'm thrilled to be here tonight and thrilled to be your MC and to welcome you all to this inspiring and significant event. And when I say you all, I mean everyone in the theatre tonight and everyone who's streaming online. Welcome to you all too. This event is the National Palliative Care Week Lecture, and it's in its second year. And in many respects, it lays a foundation for a very important week of events and advocacy. The National Palliative Care Week runs from Sunday, May the 11th, which is this Sunday, to Saturday, 17th of May. And this National Palliative Care Week is an important opportunity for us all to continue the conversation about the essential role that palliative care plays in the ability for us all to have the end of life we would like, a good end of life. And it is life we're talking about in many respects, you know, really. It's not just death, because death is a moment, a final, gentle breathing out, a blowing out of the candle. But life up until that point can be anything from calm, controlled, serene, peaceful, to chaotic and fearful and traumatic. And tonight we will discuss ways of improving the ability of our entire community to make sure that we all have a good end of life. That things, you know, we know things can go right and we know things can go wrong. And tonight we're going to discuss how we can build on the capacity for the health and care sector to actually be able to deliver the palliative care services equitably so that everyone who needs them can access them, which is most of us. The theme for Palliative Care, National Palliative Care Week in 2025 is, what's your plan? And this is a question that challenges and inspires different groups. For individuals and families, it challenges us to think about our own future and quality of life, to have the conversations with loved ones, to make informed choices, to decide how we would want to be cared for. For the health and care sectors, it prompts reflection on capacity, innovation, and the readiness to meet growing demand in a community that hopefully feels empowered by end-of-life planning. And for government, it calls for accountability, opening up opportunity to discuss policy, investment, and strategy, all essential to address the future needs, palliative care needs of our community. And we need each of these sectors to have a plan. I discovered that it is all very well for individuals and families to be informed and to make informed decisions, to have the conversation about end of life, to understand our loved ones' wishes, and to make the plans and promises to fulfill them. But it can all turn to dust in your mouth. It is all meaningless if this promise of the care they want is actually undeliverable. Now, many of you may already know that I'm speaking from bitter experience here. And as patron of Palliative Care Nurses Australia, I did feel very well informed for a civilian. I took my lead from the inspirational palliative care people I had met over the years, and I spoke openly and fearlessly with my parents about their death. Good for me. We had numerous discussions, whether they wanted to or not, because I insisted with confidence that these conversations were the only way possible to get the death they wanted in the place they wanted. And what they wanted was to be at home, to be comfortable as possible, and to have their family around them. And my mother's always been pretty upfront about death. She's been speaking about dying since she was about 40, and I now realise it was probably menopause. But she used to say to me, and she said it her entire life, Jean, you know, in case I don't die, but I just lie there like a vegetable, I want you to turn off the machine. Promise me you'll just turn off the machine. And actually, I don't even know what machine she had in mind. Possibly the iron. But I have promised my parents for many, many years that I would do everything possible to give them the death they wanted, to give them everything they needed to have a good end. I said to them, you'll both be safe, you won't suffer, you'll be in good hands. We'll have compassionate palliative care nurses to support us all, to give you whatever you need. This was my personal promise, because I believe that if we had taken care of our side of things, you know, responsibility for filling in advanced care directives, having all the sometimes difficult end-of-life conversations, I believed if we planned our side of things, then the system would take care of their side of things, their responsibilities. It had never occurred to me, it had never crossed my mind that the constant, that actually, you know, my constant nagging them to, you know, have these discussions and the constant encouragement that we all got to have these instructions, that it was not something that the system could actually deliver, that the death they wanted was not actually possible. Well, it certainly wasn't in my parents' regional town, as we found out. When my mother was dying, not one aspect, not one choice, not one wish in all the planning was able to be fulfilled. She wasn't at home, she wasn't surrounded by family, she had no palliative care, her symptoms weren't managed, and she was not free from spiritual, emotional, psychological, and physical distress and pain. But as a general once observed, no plan survives contact with the enemy. And that's what it felt like. It felt like the system was not on our side, the health and care system. And Mum's journey started, as you would know if you've seen the palliative care campaign, in residential aged care and ended up in hospital. And, you know, I feel I should have anticipated this, because it had always been hard in their area to actually get any referral to palliative care. My experience in the healthcare system was that nobody really wanted to talk about palliative care. Palliative care, in my experience as a consumer, was treated as some sort of mysterious adjunct to healthcare. You know, it was like it had multiple gatekeepers who liked to keep the slightly unsettling world of palliative care at arm's length. The GP didn't really want to talk about it. He'd go, oh no, I think everything's all right, you know, to me and my mother who's 99, you know, back to the thing. And in hospitals, in the numerous crises that my parents had going in and out of hospital, nobody really wanted to talk about it there either. And so I feel like I should have anticipated that we would have trouble, but I just sort of operated under the belief that when the time came, when palliative care was needed, then the palliative care team would just miraculously appear like the Avengers, you know, and save the day. But that didn't happen. And instead, for nearly a week, Mum was taking up a bed in hospital that would have been better used for someone with an acute need. And I look back and I wonder if all the gatekeepers, we couldn't even get a contact number, who wouldn't give us any information, you know, and as I said, we tried for years and years, we're actually hiding the fact that those services didn't really exist in our area, or perhaps they were so limited that there was some sort of rationing going on. A bad death reflects badly on us all, because we actually have the skills, the information, we have the medical, you know, wherewithal, the treatments to actually make sure people's death is managed in a way that it is, you know, is what we would call a good death. a good quality end of life. So we just need enough resources for our health and care system to provide that care, to provide those skills that are already there for all of us, from the first breath to the last soft breath. This year's lecture comes at the dawn of a new government, a great opportunity for us to put palliative care firmly on their agenda. The lecture is being live streamed, as I mentioned, to a large online audience, and a video and podcast recording will be published to the Palliative Care Australia website next week. Thank you so much, all of you, for being here. You're in the theatre and online. Thank you for lending your head and your heart and your hands and coming out on a fairly brisk evening. And if you'd like to get further involved, which we welcome, everything you need to know is on the Palliative Care Australian website. Palliative Care Australia website. So please go to it, and there's a toolkit for us all to work out how to do things online and social media, and just sort of really getting all our weight behind this campaign and this opportunity in the coming week. My story is, sadly not unique by a long shot, and nor is it even the worst by a long shot. Tonight we are absolutely honoured to hear from one family with two different end-of-life stories, end-of-life experiences. Heike, Fabig and Richard Boele live on the south coast of New South Wales. They welcomed 3 sons into the world, and 2 were born with disabilities. Tonight we are privileged to share in their deeply personal journey of supporting their 2 sons, Kai and Bodhi, who died 6 years apart. Bodhi was able to access the care and support that maximised his quality of life till the very end. Tragically, Kai was not. Heike and Richard have a unique perspective on the parts of the system which work and give the skilled care and the comfort the patient and the family needs, and also the experience of the parts of the system that they don't work for the patient and family. And not only do they don't work, but they actually work against them. It's a powerful message, and one that we hope will encourage the government at the beginning of their new term to embrace and enact the next steps of health and care reforms. And now, to share their story with formidable strength and courage, I would like you to give a very warm welcome to Richard and Heike. Oh, Caroline, give a hug. We're going to here you.
Thank you everyone for coming to listen to our story, and thank you to everyone online.
I guess we cannot really start without acknowledging the Ngunnawal people on whose land we are meeting today, but it's also important to acknowledge that some of the story that we're going to talk about happened in the Ku-ring-gai area of the Eora Nation in Sydney, and in the Wandi-Wandandian area on the border of Dharawal and Yuan country. It's a little bit complicated, but basically known as the Jervis Bay area in the south coast. So there you have our family.
I've got the clicker.
You've got
okay.
the clicker?
I'm in control.
Cool.
I'm going to make sure the right picture's up there at the back.
I will just look at the front then. So we have the 2 adults in the back, obviously are Richard and me, and in the front row, the 2 children in the wheelchair. The youngest one on your left is Bodhi, and then you have Kai, and then our 3rd son, Yasha. I guess we have to start at the beginning. The question we always get, what have they got? To which our eternal answer is, we don't know. It's probably the same thing, whatever this thing is, but they present very differently. So we have had a number of genetic tests done because we are fairly certain that it was a genetic to use fancy words, autosomal recessive condition, which basically means that we both happen to have a little mistake somewhere on our genetic material. And if you get that little mistake from one of us, you're fine. Although I'm not sure we are fine, but you know what I mean. And if you get it from both of us, then you have this thing.
And the geneticist said that it was really unusual, that it was a 1 in a million chance that we ended up not with one, but actually with 2 children. And I always thought we should go out and buy lottery tickets, which we actually did, but I can tell you we never won anything.
Hasn't worked. And this unknown thing, what it does, it caused demyelination and neuropathy. Demyelination, the best way to explain it is think of your phone charging cable. The metal cable inside is your nerve, and then you've got the white coating, which protects the electronic part of the cable, and that white material slowly breaks down. So you lose gradually the ability to do things, but it also results in a lot of pain, because when these nerves are exposed, it's incredibly painful. I'm explaining this because it's kind of an important part of the whole story, as you can imagine. But the kids were very different. So Kai used to walk. He had autism. He was diagnosed possibly with bipolar, although looking back and knowing what we know from the autopsy, we are starting to wonder whether his mental health issues were actually pain that was undiagnosed and untreated. And he would have very clear dips in his journey. He would suddenly just wake up and not be able to walk anymore. Whereas Bodhi, he never walked. He had no autism. He was complicated in other ways. Bodhi was born presenting female, and it was when puberty hit, he also announced that he was a transgender, so there was a slight added entertainment there, working all of that out. And his degeneration was very, very slowly and gradually.
But we just want to introduce both of them, because I think it's important for us to acknowledge the people that they were, for us to be able to introduce you fully to the experience that was or wasn't palliative care. So, Kai. He was born in November 2000. He died in March 2018. He had no palliative care, but he was very funny. Kai loved the social interaction. If you came to visit us and Kai was still with us, the first thing he'd do is ask you, what would you like to drink? Yeah? He genuinely loved the social aspect of life. He loved serving, he loved caring for people. He was always deeply concerned when people were unhappy, or when people clearly weren't quite right. He was religious, which was, and when I say he was religious, we think in hindsight that when he asked to be baptised, he died in March, he asked to be baptised in January, he'd found a connection with a local pastor, and we think that was him preparing for death. Yeah? At some level, while we never spoke about death with Kai, he never raised it. And that was something that we were taught, was you go with the child where they want to go. If they raise it, you go with them. He never wanted to go there, so we never talked about it. But he had this connection with this Baptist pastor, which was really funny because his biggest religious focus was Mother Mary. So those of you that are religiously trained will understand a Baptist and being accepting of Mother Mary, but it was genuinely a really strong and powerful connection that he had. And as embarrassed as we are to say it, considering our politics, and some of you may know my sister who's currently trying to win the seat of Bradfield, he was a Trump supporter.
Yeah, he loved Donald Trump because Donald Trump was going to fix everything. And that is, you know, from his point of view, it made perfect sense because his life was very complicated, and he, despite not wanting to express it so much to us, he was acutely aware of it. And his his death was, you can already see that I'm starting to struggle to even put it in words. The word that comes up is disempowered. He was disempowered and so were we. I don't know if it was accidental that it happened this way. I wouldn't want to cast blame on anyone in the healthcare system, but that was the reality for him and for us. Because Kai had had many treatments and often would go to a treatment and then have to stay in hospital for quite a bit, he did not want to go to hospital anymore.
And when we say quite a bit, I mean, sometimes he'd be in hospital for months, right? So one of us would be sleeping next to him. So his experience of hospital was intense and long. And it's fair to say, you know, the treatments that he had were invasive and they were painful. You know, that's why he didn't want to be in hospital, even though it did make him better most of the time.
So as a result, I vividly remember our first meeting with the palliative care team at Westmead Children's Hospital on the 14th of February. I mean, what a Valentine's event that was. We had palliative care team there and we had the neurologist there who was actually in many ways the pediatrician or the primary doctor for Kai, because he was the one who understood him the most. And I will never forget that meeting. The two teams were at loggerheads. The palliative care doctor was upset that the neurologist had prescribed pain medication that probably the palliative care doctor should have prescribed, but because the doctor was off sick and the neurologist went, I can't let this child go home in pain, he prescribed medication, and the palliative care doctor did not like that.
And in fact, I can remember him saying as he was writing out the script, he said, geez, I haven't written out a script for this since I was in medical school. That's how long it had been since he'd written a script for, what was it? It was oxycodone, I think.
I think endone. It was endone.
That's right, it was endo.
You know, not exactly world-shattering medication, really, but it really got the palliative care doctor riled up, who then also found out that we had gone and visited Bear Cottage in Sydney, the hospice for young kids, and the doctor was very unhappy that we had done that.
Yep, because our child was too old. We shouldn't have gone there.
You know, which he wasn't at the time, but they started this whole debate about how it shouldn't have happened, and we are sitting there going, excuse me, our child is dying. Can we get some help here rather than you lot fighting? And you know,
and probably what's really helpful is to understand that we as parents thought that Kai was in his last weeks and days, whereas the palliative care doctor had a professional view that Kai had months, if not longer, to live. So that was the fundamental difference in view, which was then, I guess, playing out in terms of behaviours. Hopefully that just helps you make sense of why we were having what was, when we reflect on it now, and hopefully when you hear it, you just go, but how's that possible that you end up in that type of conversation with a health professional?
You can maybe see it in this photo that there is an NG tube, a nasal gastric tube in Kai's nose. So he had come to the point where swallowing was no longer safe for him, which was a very big bummer because he was a foodie. And he also knew where things were heading. And so he had decided that he was going to eat again. He had said that if he wasn't allowed to eat, he was going to drive his wheelchair down in the bush and off the cliff at the end of the street, or go to the Pacific Highway and drive in front of a truck. Neither didn't seem a very good option to us, and we knew where it was going, so we went, okay. So he was eating, he was drinking, he had pneumonia. We were given 10 packets of oxycodone, and that was the palliative care we eventually received.
And that was a surreptitious meeting, right? Because we went to hospital for one reason, and then we arranged for the palliative care doctor to bump into Kai so that they could have a conversation and she could then prescribe that. What happened then, as we got closer to Kai's sort of final day, is we ran out of antibiotics because he had low-level pneumonia the whole time. So I went to our local GP with Kai to ask for a new prescription. He said, he listened to Kai's chest and he said, this young man is about to die. And I went, yeah, duh. And I said, look, all I want is an extension of the antibiotics. And he said, I'm going to ring his palliative care doctor at Westmead because I'm just concerned, about where Kai's at. And I took a deep breath. He rang the doctor, who then said on the end of the phone, and this was the doctor, by the way, who we had this difference, very significant difference in view of the prognosis. And she called for a medical review. Now, for those of you that know, if you're sitting in a GP's office and a medical review, that means you have to go into hospital for a full review of the patient. And I could just see Kai sitting next to me tighten up at what he was hearing, that here he was going with me to the GP to get antibiotics and that turning into a forced visit to hospital, which was the last thing he wanted to do in his last few weeks, let alone days. So I took a deep breath and tried to argue it with the GP after we got off the phone, and he just said, Richard, I need you to go because if you don't go, you're going to invalidate my GP insurance. Exactly. And so we went home. I just said, right, if we're going to go, let's call the ambulance because we were well practiced at this point. You do not want to go to ED yourself. You don't present. You go in an ambulance. You go straight through. So we rang the ambulance turned up. The first thing he said is, your forms are all in place. What am I doing? This child needs to be at home dying. He does not need to go to hospital. I'm very happy to call it. And I said, well, I've been told by the GP that if we don't take Kai, I'm invalidating his insurance, his medical insurance. So we got in the ambulance, went to hospital, went straight through. Within 5 minutes, the director, the head of ED on that day, turns up and says, what are you doing here? You should not be here. And I said, we've been forced to come here by the head of palliative care who's ordered a medical review. So he said, well, leave that with me. He went back. He came back 10 minutes later. I can't find her. She's not available. And I said, it's like 6:15. I said, what do you mean she's not available? I can't reach her. She's not answering her phone. And I said, well, what do we do? And he said, well, I'm sending you straight back home, which is where you should never have left, because that's where Kai wanted to die. And he could see the condition that Kai was in. And the ambulance on the way, he was so scared he was shaking and started to sweat. That's how nervous he was because he thought he wouldn't get out of hospital and he'd have to die there. And he'd already been saying to us again and again, I do not want to die in hospital. I want to die at home. He didn't say it with those words, but we knew what he wanted. Yeah, he communicated that.
Well, he was very clear, no more hospital.
That's right, he kept saying that.
And when we had conversations about, yes, but you're eating, well, yes, Mummy, what will happen then? Well, you have pneumonia, and if I keep eating, well, the pneumonia is going to get worse. And if I don't go to hospital, well, then it will kill you. And he went, okay. And he made himself a cup of tea. So he knew full well what he was doing. And I have to add here that the whole thing was a little bit more complicated because you're probably all wondering, well, why is there no palliative care? Where is something like the community palliative care? Well, on that meeting on the 14th of February, a referral was going to be made to the community palliative care who could then take over and we would not have to go to hospital anymore. That referral, I can't really say what happened to that referral beyond the fact that after the event, I made a Freedom of Information request, and the referral was dated the 2nd of March. No, it was dated the 23rd of February, but it contained something that happened on the 2nd of March. So I don't know what happened there. I know it was received on the 2nd of March. Kai died on the 4th, which was a Sunday, so we were never seen by the community team because it came on a Friday at 4 o'clock and they couldn't come and see us. And all of this to us felt like there was a total denial of agency, of we were the problem. The responsibility was shifted to us. The referral actually contains the words, Kai's parents are unwilling to have Kai admitted. It wasn't us that didn't want him admitted at hospital. It was Kai who didn't want to go. There was no acknowledgement of his wishes and what he wanted.
Oh, there we go. I got the right way around. So Bodhi, quick story. We've got to move on. We're running out of, after 20 minutes. So bear with us as we'll
speed up a bit.
We do speed up because I think Kai was what went wrong, but Bodhi was what went right. So Bodhi, he was born in 2016 after you had six, that's right. After you had your tubes tied, because we'd had that. Can I just, but from a gender perspective, I'm just going to have this and put this out there, is we had a debate for weeks about who was going to get the snip, right? And can I just say, I was like, no, much easier for me. I did the research, I'm going to go. I lost that debate because you had some arguments that in retrospect...
Very sensible arguments.
But I have to say, in retrospect, it was wonderful because we got 18 wonderful years with, oh my God, such a young man that was just a gift, it was. And Bodhi was the ultimate pocket rocket. He was out and proud. And when I say out, you could easily say he was out, proud and very loud. I don't know who he took after, but look, that's another story. He was also an activist. That was clearly running in the family in terms of using every opportunity that he could to advocate for positive change. I'm very pleased to say that after he died, the headmaster finally did get a ramp to the second-hand uniform shop at school, and he'd spent 2.5 years campaigning for that. So, absolutely amazing young man.
And in some ways he was unlucky, because he was very aware of the fact that he had the same something as his older brother. And so he knew what was coming. He was there when Kai died. Everyone was at home, so he saw what was to come. But on the other hand, that was very lucky, because unlike Kai, and also being his personality out and proud and dealing with it, he took control. And he made us take control. So we had learned our lesson. We avoided the hospital. We were also very lucky that at that time, the New South Wales government had created a big bear cottage. Kai didn't like bear cottage. It was full of, fluffy teddy bears and things, and he was 17 and it just didn't gel for him. But New South Wales now has the Adolescent and Young Adult Hospice in Manly, the AYA, which had just been opened about 2-3 months before we kind of started having the conversation with Bodhi.
We were like in the first 10 or something.
Yeah, third or fourth
early on. Yep.
Patient.
Yep.
And that is an amazing facility that deals with pretty much everything. And we also, from AYA, got a referral to, by then, the Shoalhaven Community Palliative Care, who were absolutely amazing. So between AYA and Community Palliative Care, we were in charge. Bodhi was in charge. He made a bucket list. He had 10 items that he put on his bucket list. We're proud to say we managed to do 9 of them. Skydiving wasn't possible because of his medical issues.
He had full spinal fusion, and the risk assessment was done because he actually knew one of the founders of Sydney Skydiving, because his wheelchair had broken down outside his house, down in Vincentia where we live, and he came out and got his toolkit, and he was an electrical engineer and got the wheelchair going again. So Bodhi and him were well connected. And he said, look, we did the risk assessment and unfortunately we cannot find a way to do it. I understand that Bodhi doesn't care if he dies when he actually lands, but unfortunately we are a commercial company and it would invalidate our insurance and I'd be out of business. So he had a good he really had a good crack at it.
But I'm very proud that one of Bodhi's friends actually did
Jack,
it on his behalf.
He did. Jack did it for him after he died, yeah.
Bodhi also, together with the team at Aya, they developed this document called Voicing My Choices, which was amazing. Like basically the staff at Aya started the conversation with Bodhi about what do you want? How do you want to die? What should happen, what shouldn't happen? Medical things like what level of intervention do you want? Practical things, where do you want to die? Practical things like funeral, which was very handy for us because we knew exactly what to do. And also when some of our more conservative friends were frowning that the funeral was in the brewery, we could just say, but it was Bodhi's wish. And he told us that he wanted to be cremated and his ashes spread out onto the Humpback Highway.
And I guess one of the really practical things of having that access to a service like that, left-hand side of Bodhi was the Saturday morning of the Taylor Swift concert. All right, so we'd made, as happens, as the pain increases, the particular treatment then needs to be changed, right? Because you've got different pain thresholds. And in the previous sort of 3 or 4 days, we could see pain increasing. Woke up Taylor Swift. What do you want to do, Bodhi? Do you want to go to Taylor Swift concert or do you want to go to Aya and let's get a new pain management regime? And you can see what he chose. He actually chose going to Aya, which we rang up. 2 hours later, we were there and we'd started a new treatment. And that's just extraordinary care to be able to have access to.
That photo is literally 2 days difference.
Yep.
And I have to, on this point, I also need to mention that Bodhi had discussed with the local palliative care team that he wanted to look into voluntary assisted dying, which is, in a roundabout way, I think what Kai did. As it turned out, Bodhi never chose to do that because he got good pain relief. It was just no longer an issue.
Yep.
And I think that, did you do your clicker?
Yeah, no,
I
was just remembering the moment, like, it was just so sweet because we would start a new pain regime and Bodhi would kind of go, I think I'll make it to the end of the year, right? Because you get that real hope, that real kind of like, oh my God, I feel like I'm me again. And that is the joy, the moments of joy of really good palliative care, and just reflecting on, Jean, your experience. I mean, just the right drug at the right time makes a huge difference.
And,
yes,
and it meant that we could go and do things like he wanted to swim with dolphins. So we did that. We drove to Uluru in 3 days, had 2 days there, drove back in 3 days. We did some crazy stuff because he had the right pain relief. And that is the impact of good palliative care. It made Bodhi's death better, but it also made his life better, especially in those last, I would say, 3-4 months. Bodhi had the best possible death he could have had. In Kai's case, thank God for pneumonia, the old man's friend, as they used to call it. But boy, it could have been different, and it should have been different. Palliative care gave Bodhi choices, and Kai was not given that opportunity. And it's hard to say it out loud, but Kai's last weeks were pretty miserable. He took control by eating and drinking, but that's not how it should have been. The impact on us, in a bizarre sort of a twist, Bodhi's good death actually made Kai's death more traumatic for us.
Because when you go through one death, you've got nothing to compare it to, so you kind of go, oh, that wasn't great, but I guess that's death as we do it, right?
And knowing what's possible and what should have been possible, what he missed out on, and what we as a family missed out on, how much longer would he have had? He could have had a bucket list. He could have done things. We could have had some fun, and none of that happened. The other thing is we managed Kai's death pretty much on our own. We got 10 sachets of OxyContin, and that was it.
And then there was Dr. Google, otherwise known as Dr. Palliative Care, and that's what we relied on. And fortunately, I'm a Buddhist, so in my teachings, we spend a lot of time understanding the process of death. And it's actually quite helpful because Kai followed it really neatly. So for us, it was that's what we drew on. To manage Kai's death. Also what we did was, we're pretty go-getters. I can't believe it took me over a week to find out that in a particular health district, if you have a private palliative care provider, you can self-refer. This was a revelation, but I didn't discover it until Friday morning, even though we'd spent 2 weeks hassling the hospital, hassling that palliative care doctor. Please refer us. We think Kai's days away from dying. Please just refer us so we can get the support in the last few days. That referral didn't go through until that Friday afternoon before Kai died on the Sunday. And I also managed to get my self-referral through just before that one went through. So I had a phone call with Hammond Care, who were fantastic. And they just said, we're so sorry, it's 3:30, it's too late for us to get out to you for the weekend, but we'll come 10 o'clock Monday morning. We'll be there first thing. I actually got a proactive phone call them on the Saturday saying, so I see you're on the list, so sorry we couldn't get out to you. We'll be there, we'll be there on Monday morning. Please, anything else we can help you with on the weekend, give us a call. So when Kai woke up on Sunday morning and he couldn't see, we knew what had started, right? That we were genuinely in those last hours of his death process because he couldn't see anymore, even though he tried to get out of bed and go to church because it was Sunday. And we're like, Kai, mate, you can't see, But for him, it was just like he just wanted to go to church, and at 11 o'clock he fell asleep, and we knew that we wanted to keep him asleep. And that's when I rang Hammond Care and I just said, look, I've got these OxyContin sachets, but I know from researching on the web, if I give him too much, I'm going to end up waking him up. He'll throw up, right, because of the toxicity. But I don't want to give him too little that it doesn't keep him asleep. So what can I do? And she said, I'm really sorry, but please do not use his name. And I said, why? And she said, because we're not allowed to give advice in relation to a patient that we haven't seen yet. It's just the procedures, it's just what we have to do. And I have to say, in that moment, to be told as your son's dying in the other room not to use his name when you're trying to get advice around how to give him the best possible death in those last hours, it hit me hard. And so we then started to talk about a hypothetical 17-year-old with a certain weight to get a hypothetical dose advice. And of course, that later that night, I rang them up and I said, look, don't worry, because he died, at 8 o'clock that night. And I have
to say, they were devastated about that. That's all I can say. They were devastated. The other thing that I still struggle with is this referral to the community palliative care team that supposedly was made on the 2nd of February but contained things that happened on the 2nd of March, 2 days before he died. We have talked to the hospital about that. They close ranks, and I sit here with this little bundle of anger because I feel something is wrong and there's nowhere to go. And that should have all been avoided. And that brings us to why are we here? And this is actually the last slide, so you can all take a deep breath after this. Why are we here? Why are we telling you this dreadful story? Simple. Better is possible. It shouldn't have to be this way. Everyone should have access to palliative care when they need it. And we are here because Kai missed out, and we still don't really know why, and we still ask ourselves every day, why did Kai miss out? And how can we avoid Kai's experience for others? And as hard as it is, with like literally 2 days to go until the anniversary of Bodhi's first death, that's why we're here, because it has to change. And I think we'll end it on that.
I think we live it. Yeah. That's it.
Thank you.
Thank you so much, Heike and Richard. It's very hard to even make any comment about that, because your experience is so profoundly distressing on one hand, and the other one, as you said, the more joyful one has made the distressing one even more traumatic. So, but all we can say is we thank you we are so sorry you went through this. We thank you so much for sharing this story. It's incredibly important for us all to see how it can go so terribly wrong, so that it doesn't continue to do this for other families. And thank you for your incredible courage and honesty in sharing it and revealing yourselves and making yourselves so vulnerable and reliving it again. So thank you. Just a round of applause for appreciation. And as Heike and Richard said, the whole reason behind going over these profoundly traumatizing moments in life is so that they don't happen to others, so that change is made. And now adding his authoritative voice to our conversation tonight is our next speaker, Dr. Peter Allcroft. Peter is a palliative care specialist based in Adelaide and the chair of Palliative Care Australia. And I think with Peter's guidance, we will honour the lessons of Kai and Bodhi's experience and hopefully reinforce the next steps of reform to the newly elected 48th Parliament of Australia. So please give a very warm welcome to Dr. Peter Allcroft.
We all need to take a bit of a breath. Thank you and good evening. A really warm welcome to all of you, everyone that's here in the auditorium, but everyone who is online also. Thank you for your interest and your support for Palliative Care Australia, the goals and the aspirations to improve the lives of people living with life-limiting illnesses. National Palliative Care Week this year is focused on discussions around encouraging patients and families to discuss what is their plan. The way in which people die has changed radically. It is now much later in life. It's often prolonged. The number of people that we anticipate to care for, the number of people aging with chronic disease is increasing exponentially. The number in the next decade that we will need to care for is going to be substantial. Dying once was the province of the family, the community, but we have lost that. It has been medicalised and now is predominantly the role of the healthcare sector. And we often see that, unfortunately, treatment continues to very late in someone's life, in their last few days. And doctors recognise that dying and acknowledge that dying is far too late. A review of patient records in Australian public hospitals revealed that, on average, doctors were acknowledging and recognising that someone was dying only in the last 48 hours of their life. And they really have denied that patient, that family, their loved ones, the opportunity to prepare for that impending death. Richard, Heike, thank you. I am lost for words and I am struggling to hear the bad things that happened. The good, the bad, but your courage and resilience and strength, and your desire to improve palliative care and end-of-life care for others. I am sorry for the contrasting experiences that you experienced and described. You've been able to experience the best aspects of what our complex healthcare system has to offer, but have unfortunately experienced the challenges that are experienced by patients and families all too often, and for that I am sorry. Unfortunately, we still hear stories that surround people's end of life being far from optimal, the inability to access basic palliative care, the absence of humanity and dignity. Those people that are on the margins are often left behind. The manner in which a person dies leaves a significant legacy, and I don't need to add to that. Can I ask you all to consider what a good death might look like? What would be important to you if you or a loved one were faced with a life-limiting illness? What would be your plan? I'm going to let you ponder on that and return to it later. I work in a healthcare system that is complex, siloed, it's overstretched, it's under-resourced. There is the potential for inappropriate and futile care. It's occurring within that complex landscape and people feel powerless to speak. Jean's experience, Richard and Heike's experience. We know that when palliative care can be involved, that it results in better outcomes for patients and families at the end of life. Palliative care is an approach that explores all of the dimensions of human experience: physical, psychological, the spiritual, the existential, the social. Just paying attention to someone's mental health can have a significant impact on their experience, the way they experience pain. And you may not need as many strong opioids if you pay attention to someone's mental health. At its most simple, primary palliative care that should be delivered by all healthcare practitioners, our general practitioners, our nurses, our cardiologists, just acknowledging a person's stress, acknowledging their symptom burden can make a meaningful difference. Spending a little bit of time just finding out what's important to you, what are your goals, starting to have a conversation about limits of care and advanced care plan. Specialist palliative care, on the other hand, I get the privilege of working in a multidisciplinary team with nurses, allied health staff, physiotherapists, occupational therapists, art therapists, music therapists, spiritual care workers, and the odd doctor. We do make a difference in people's lives. We can reduce the number of people that end up in hospital with unplanned admissions. We can help to look after someone's care at their place of preference. But unfortunately, we often get referrals far too late. And if you look at the data in Australia, the average length of time that a palliative care services has someone to look after is 15 days. It's estimated that we need at least 3 months to really make a significant difference to that person and that family's life. Far too many people don't have access to palliative care. Our rural and remote patients, our First Nations communities, our multicultural communities, those that are homeless and those that are living on the margins. The socio-demographics of health play a huge role on access. In our hospices, we don't have enough beds to provide the care for everyone that needs that care. Our resources also in the community are often lacking. As our community becomes older, frailer, and encumbered with increasing number of chronic disease, we will need to care for this group of people. It is frightening to see that dementia is now the second leading cause of death in this country for all genders. And in women, unfortunately, is the leading cause of death. It's estimated that 75% of people who die have the potential need for palliative care support. That would equate to 150,000 people per year in Australia alone. How are we going to look after this group of people? So Palliative Care Australia is asking the incoming 48th Parliament, what is their plan? What is their plan for people living in Australia who need palliative care? How will they ensure access to reliable, affordable supply of basic medicines such as pain relief? How will they ensure that people living in Australia have equitable access to specialist palliative care, rural and remote, First Nations, the extremes of age, the very young and the very old? Within the next decade, the number of people aged 85 is anticipated to triple. What is your plan to ensure that there is a workforce to look after this ageing population in the community, in the aged care facilities, in the hospitals? Will there be the trained doctors, the nurses, the allied health professionals to have that basic decency to provide the humanity and dignity required? How will they ensure equitable funding? Actually, investing in palliative care saves money. The return on investment for putting into palliative care is quite significant. And what is the government's plan for investing in grief and bereavement? This should be seen as a public health priority. Specialist palliative care teams care for people and their families faced with life-limiting illness, heart disease, lung disease, motor neuron disease, dementia, cancers. We provide care, comfort, humanity, dignity, and we prevent and relieve suffering. What is less appreciated by our role in palliative care is the role of building health in our society, empowering our communities, building a network of support within the community, to build resilience within a community, but also normalising the dying experience. Because dying is not just a physiological event. It is a social event, it is a relational event, it is a spiritual event. I asked you before to consider what would be important to you if you were faced with a life-limiting illness. Some of the features that contribute to a person's good death include being with the people that are important to you, being in a place of your choosing. That might be home, but it might be a hospice, or it might be a hospital where you feel safe, or the aged care facility where you've spent the last few years of your life. People want to have information. They want to be able to plan. They want to have healthcare professionals who have trust in and faith in. They want to have those unmet needs and those symptoms well managed. But they also want to have time to prepare, to give thanks, to make amends, and to say farewell. Life and death are intertwined. It reminds us of the fragility, the wonder, and the beauty of life. We know that a person's wishes, goals, plans, they will change along that journey. We plan and prepare for weddings, birthdays, babies. Why don't we plan for our death? Why are we not looking and saying, what's important to me? So this Sunday is the start of National Palliative Care Week, and I invite you all to consider what will be your plan. Thank you.
Well, thank you so much, Dr. Peter Allcroft, for covering so many aspects of end of life in your speech then. It was really important, and for us to also understand too that although we go the system, that when you actually work in the system, it can be incredibly hard for you to be able to do what you want to do as well, you know, for health and care workers to be able to function to the full capacity of what they want to give and how they want to contribute. So to be reminded that it's overstretched and underfunded, and people work in silos, and I mean, everything you've said is something that we can talk about very soon. We're going to before we open questions to you all, so think about some questions that you might like to ask, and so that we can just dig a little deeper into this topic and see what has triggered things for you and what you would like to ask. I have one last special person I'd like to invite on stage, and I'd like you to warmly welcome to this stage the CEO of Palliative Care Australia, Camilla Rowland. Oh, sure. Okay, no worries, sorry. Is that, no, let's have a look. That's it. Oh, my first PowerPoint. Hard to believe, right? All right, thank you for joining us, Camilla. You've heard everything that people have been saying. I mean, as CEO of Palliative Care Australia, and I know Palliative Care, hang on, I'll use my microphone. I know, can you hear everybody? Everyone's got to turn on, great, only me didn't pick it up. As CEO of Palliative Care Australia, and I know for years that most of the campaigns have been to inform the community about our role in planning and talking and planning and all these things. What does it feel like to you when people know there's palliative care there, they are planning, but they can't access the services?
Yeah, look, we have a great example. We recently ran a campaign petition for their federal election campaign, and we had over 40,000 signatures in just the space of a couple of months. And when we looked at the comments, and of course those people were supporting our campaign for better access, but when we looked at the comments, it seemed to be divided into two groups. One group was anybody who could access palliative care talked about a great experience and how important it was that other members of their family and their friends in times to come should have that great experience. But the vast majority of people who made comments on this Change.org campaign said we could get nothing. We didn't matter how complex we were, if our loved one didn't get anything at all, I mean from anywhere, not just the palliative care service, but the doctors, the GPs, the oncology, they got nothing. And there were quite a number of people who died with pain uncontrolled and symptoms uncontrolled. So it has really brought home to us even more so that this gap is widening of people who can't access anything. Right. So if people have a plan, we say, do the plan early. It should be a living document. It should be iterative. So as your journey changes, your discussion and your thinking might change with yourself and your family. But when you do have discussions about a plan, you start to prepare and think about what exists in my local health district, what exists in my area, that I can start to have those conversations. At least the plan starts that conversation.
Yes, well, I suppose, you know, when you plan, you think it's going to fall into place. So part of the plan has to be to source the services and get in touch with them and break through to, you know, just fight for the referrals and everything early on. As you were saying, most people only have palliative care in the last 5 days, and then it's a scramble. Whereas if we could introduce it earlier, I remember one of the first palliative care conferences I did back in 2011, there was an expert saying palliative care should be introduced early on if you have a life-limiting illness, and you know the acute care goes like that and the palliative care goes like that, and then you can get all those people you were talking about, all the allied health, the team together, the community and the professionals all together to create a team that will take you through right to the end. You know, music therapists or whatever you want as well, just building that. We will open to questions to the floor now, and then we'll see who would like to answer the question. May I have a question from the floor? Yes. If you'd like to say your name, and there's a microphone too, so speak right into the microphone if you wouldn't mind.
Good evening, and thank you for sharing your stories. I've been a palliative care nurse for 20 years, so I've seen a lot of things. I guess there's 2 points to my comment really, rather than a question. My question maybe is to Camilla. I think a lot of the community, most of the community, don't realise that most doctors in their undergraduate training and in their medical training receive maybe 2 lectures on palliative care. Most nurses and allied health professionals receive a tuppence of palliative care training. So when we're finding that our primary healthcare providers are not meeting our need or not responding to what's going on, what we're actually seeing is mass ignorance. And I really want to say that part of our plan has to be making it absolutely compulsory that every single health professional receives proper training about dealing with palliative care.
And look, I think you've made a really important comment about the level of training that people receive in undergraduate training. What we do know from universities that deliver medicine is that when doctors are registrars, they do receive some palliative care training. But here's the thing, you get to choose, for example, if you're a GP, whether you want to focus on palliative care or not. And, there is a school of thought that says that GPs who develop that therapeutic relationship with their patient, so that that patient's always seeing the same GP, they've developed that relationship, they're more likely to be involved in the delivery of palliative care or end-of-life care. Those big clinics where you might see 1 of 10 GPs or more, you're not necessarily establishing that therapeutic relationship, and therefore that GP may be less inclined to follow up, unless of course they've got a particular interest in palliative care, and we know many GPs do. But to say that GPs, for example, are going to deliver all the other care that specialist palliative care doesn't deliver, for non-complex patients, I think is a concern, isn't it, Peter? We were talking about that earlier.
I think it's very unfair on expecting all our GPs to do everything, because they are absolutely overworked and overwhelmed and under-resourced. From an undergraduate perspective, little bit by little bit, it is getting better. I can say as an undergraduate, I got nothing. I did, however, choose to do an elective with Professor Maddox on death, dying and society in 4th year, so I obviously had a bent from early on. But Ian Maddox, who was the Senior Australian of the Year, ran that at the university where I was, so I was lucky. We have students who do 6-week rotations with us in 3rd year and 4th year. We have our residents, basic physician trainees or residents who come and will do 3 months with us. And one of the greatest thrills and pleasures is to see that resident be working in a general medical ward or a surgical ward and applying the principles that they've picked up in the 3 months with us. It's little by little. We have student nurses who come and spend rotations and are on the wards with us for 6 weeks at a time. We do have allied health students there, but it's little by little. And I know at Adelaide University they have dedicated programs that they have to do a week of palliative care. And at Flinders, where I'm based, we do 3 series of workshops and communication skills, which we run with actors. It's not a lot. Trying to get into a curriculum when they can, sew up things, put tubes in things, stick things in unnatural places. We don't get a Guernsey in talking about things that are important.
But isn't there another element to it? Because at Aya we saw, and that was Northern District Health in New South Wales, you had lots of nurses and lots of doctors who came and did their prac there. Right? And we would say, what are you thinking? Are you thinking about making palliative care something that you focus on? And most of the time they'd say, it's too hard. And there's something there, because the palliative care community nurses that we had down south in the Shoalhaven, oh my goodness me, I was in withdrawal after Bodhi died. Because I missed them. They were there every day at the same time, and they became part of our family over those 3 months.
So
and
Richard,
I just wonder, how do we tackle that so it becomes a place you want to work?
So Richard, you raised a really good point. You developed that relationship with them, you saw them a lot. And from listening to you both and your story, and I've heard that you both speak a few times now, what you're really clear about is you're really good at advocating. You had a plan, Bodhi had a plan, you know. So even though at times it may not have come off, the thing is when you do have a plan, and again, as I said, that plan may change, but then you're able to better advocate for yourself. So if you have a GP who may not be as skilled in palliative care, or an oncologist, you know, if you have a plan, you're able to say, look, this is what we want to have happen. How do we make this happen? Who do we need to see? What referrals do we need? And that plan enables people to become advocates for their loved ones and to help improve that system. We then collect data, of course, from the plans if they're uploaded, de-identified data, and we're able to say, okay, these are some of the needs in society that we're going to have to think about when we're advocating for further investment by Commonwealth and state governments in palliative care.
Thanks, Camilla. Is there another question?
I just wanted to say full disclosure. I actually run the ACT program of experience in a palliative approach, which is about taking health professionals who have no palliative care exposure and bringing them into the space. But I guess my comment is not meant to be harsh on GPs. I just think it's just something we all should be educated about. And I think there is a role for navigators within the healthcare system so that families in the midst of their grief and illness aren't trying to make 40,000 phone calls and find out which website's bogus.
The navigation that you comment on is being trialled in South Australia with a Palliative Care Connect. I hope that it'll be ongoing funding. One of the biggest frustrations in life is that projects get funded for a set period of time, they're not ongoing. The Palliative Care Connect, you sometimes I think, gee whiz, I'm sorry that we need to have that, but people can ring a single number in South Australia and someone will help put them in the right place. Just like we have the McGrath breast cancer nurses, just like every state has voluntary assisted dying navigation teams, we actually need navigation for our patients experiencing life-limiting illnesses who need access to palliative care, because it is complex. You know, we don't make life easy for people, unfortunately. So the navigation, I'm really looking forward to seeing how that plays out, and that money came from federal government because of a senator's bad experience. You would expect someone who's educated, articulate, in the know. He had no idea how to get access to palliative care for his wife, and it was in a crisis, and the oncologists were still giving treatment for their cancer. But once he found palliative care, because he rang the CEO of one of the hospitals who put him in contact with us, that's where that navigation money came. And so I think it's something that we need. I'm hoping that it will continue the funding. I'm hoping it'll get positive rewards and roll out across the nation.
It's actually something that we asked the hospital on that wonderful Valentine's Day meeting. I expected, this is our first meeting with palliative care, I expected a little leaflet, like, this is what you have to think about. These are the issues you need to consider. There was nothing. In fact, we had to find out stuff and Google stuff. Why is there no little, even just a little starting point?
Absolutely. I think that's a very common thing, people just not being able to access it and GPs being reluctant to talk about it too, and not having the time. But a number or a connected, Palliative Care Connect sounds like the ideal thing. It sounds like it should have been in place for a long time and funded for a long time. Is there another question from the audience? Oh yes, down here.
Hello, my name's Dr. Stephanie Pidcock. I am a rural generalist, so I work across GP and emergency medicine. One point to make, how on earth can palliative care be 9 to 5, Monday to Friday? Point one. I mean, people die on the weekend. The second point is, with the statistics that Dr. Allcroft was quoting about the current number of people in need of palliative care and the increase in that number as time goes on, in my view, particularly in rural and regional areas where I work, GPs obviously are going to need to play a central role. But there's a couple of challenges to that. One is obviously the training issue that's already been raised. The second is doctors. So I haven't always been a doctor. I've worked in other sectors, and having come into medicine, something that strikes me is that doctors are often not very good team players. And your experience kind of highlighted that between the neurologist and the palliative care physician. And I think we probably need to do a bit of cultural change to bring that about. The other challenge is working in a rural area as a GP, we are thin on the ground. We are very time limited. Everything is based on 15-minute appointments or half-an-hour appointments in special circumstances. And palliative care doesn't fit into that model because you need to take the time. You need to understand the person. You need to understand what their values are, who their family is, what their needs are in terms of their physiological and psychosocial and spiritual needs. And the capacity for a GP to be able to cover all of those things within the GP billing model is really limited. And I just wonder whether that's also got to be part of the conversation about, you know, in terms of what Palliative Care Australia is doing and the discussions they're having with government, whether that needs to form part of the discussion about what model can be applied to palliative care, because the current GP model is very difficult to fit that in.
Yeah, we certainly asked as part of the election that one of our major asks was about considering how general practitioners are remunerated and thinking about different ways in which they can be better resourced and better remunerated. But let's also think about, in primary health, nurse practitioners, registered nurses, district nurses, community nurses in rural areas. And I know that I worked in rural palliative care in rural New South Wales and Victoria. We were very reliant on community nurses and district nurses also covering some of that palliative care role. Now that we have nurse practitioners, what does that look like in Australia? And they're very keen to build their numbers as well. So it's not just about GPs, it's also about those other primary health services and what do they look like. But even with that, we still need to think about, as Peter said, we've got triple the growth in number of people over 85 between 2022 and 2032. We can't even meet the need now. The aged care reforms will meet some.
And more people will be expecting to be able to die at home, because the new, you know how they used to have home care packages and now there's supported home packages. There's a whole package, a level 9 really, which is for palliative care, 25,000 if you're only given 12 weeks to live. So people will be expecting to be at home and use that money to get the help they need. But where's that help going to come from if they can't, all that training, that comes in on the 1st of July. So, in some ways, those people would have been in residential aged care where there at least is, some 24/7 care, but now they'll be home and trying to meet that need, and that expectation is going to be quite difficult, another challenge. And it'll need a lot more training and a lot more people being encouraged to go in.
And note that 25,000 is actually for functional support. It's personal care and housework, transport, social emotional support. It's not for additional medical support, clinical medical support.
Nice.
So I guess the 25,000, which is for the initial 3 months, and then it can be extended for another month to 4 months. If that's not enough, those people end up in aged care facilities and hospitals anyway.
Yes, it's a very difficult situation.
Oh, and then of course we need to work on the fact that it finishes at 4 months. So if you're still alive after 4 months, then what happens? So
that's right. We're very
you've got
much 12 weeks, or
that's
it's all.
right.
Yeah.
We're very much advocating that it should be assessed on a needs basis, not on a strict, 4-month time frame.
And the GP has to assess you and be willing to say, I think you have 12 weeks left. And that's a difficult thing for a GP. And then an assessor has to come and give you an allocated, package. So it's complicated.
Got to make an appointment to get in to see your GP.
What was that?
Have to make an appointment to get in to see your GP.
Oh, yeah, there's that. That's right.
And you might need more than 15 minutes.
Yes.
And if
Question,
you
Danny.
live rural, your point about 9 to 5, Monday to Friday, we sometimes have to wait 2 weeks before we get a GP appointment. So, you really got to plan your dying quite well.
Yes, down here. Thank you.
My name's Anthea Smith. My husband has been living with motor neurons disease now for 8 years, and we are sorted. We have palliative care on our side. We have a fantastic multidisciplinary team here in the ACT. But Jean, listening to your conversation about your mother, I've realised I also have ageing parents that live in central West New South Wales. In hindsight, what questions would you have asked now about the lack of services? What were the things that you should have known then? Because we just did advanced care planning last week for my husband. We live in Canberra, so we have the services available. My parents, I actually just thought, oh, we're sorted. They've done their will, they've done all of that, and now the penny has dropped. Oh my gosh, I have to deal with this, but then I also have to deal with my ageing parents. And so what questions should I be asking now of people in central West New South Wales so that I can be prepared to help my parents die peacefully?
Well, for me, I think you need to look at every single scenario. So my modus operandi for the whole time I was caring for my parents as part of the team, but the team leader, was to get them out of hospital and home, no matter what happened. And they were quite ill sometimes. And in fact, the last time Mum got sent home with hospital in home, but she had prolonged psychosis from some pain medication, and she wasn't managing at home and needed 24/7, so we got 2 weeks respite. And I didn't ask the question from the residential aged care, what are your protocols in here, and do you have palliative care? Well, I assumed they did, and they said they did. But when Mum got ill and had a fall and got ill and said she wanted to die, they said, she can't die here, we've got to ring the ambulance. And I think for me, at that point, I should have pushed back. I think I should have said, why? I mean, her home was only 200 metres away. I could have put her in a wheelchair and taken her home and, mopped her brow and done something. But so, have the numbers, who do you ring? And I have to say that my dad, after years and years, because he had coronary occlusion pulmonary disease, so he was always ringing an ambulance for breathlessness, we did get referred to palliative care for him, but when they went into the respite, we weren't allowed to bring them or the GP with us in any way. But I could have taken Mum home. So I'm always going over these scenarios, because when you have a bad death, that's the last chapter of their book, and that's a pretty powerful story, and it seems to take all the joy out of all the other stories for so long. All I can think about is that last story of me not being the advocate. So make sure you know who you ring, what and how. If that's what they want, how does it work? How is it going to work? Who are the people that are going to come in what scenario? And if they aren't there, if they're in a residential aged care, exactly what the protocols are there, exactly how much they're trained. You know, so it's not just your wishes, it's how it's going to work. So just drill right down, get the numbers, write them down, you know, and know that you can take you know that you can go home. Like getting permission, your story about having to be allowed to go home almost. You had to get permission. And when Peter was saying, you know, in the old days, most people died at home. There was no permission. It's just where you did. You know, that's what happened.
And can I just do an and on get the numbers? So we were in Aya in Manly. Bodhi said, he actually said for a number of weeks, I'm happy to die here. And then he changed his mind. And he said, no, I want to go home. So that was then Shoalhaven Health and the palliative team down there. I did not want our referral to not go right. So what did Richard do, having had the experience with Kai? I spent half a day on the phone finding out who was the doctor that would then be responsible for us. And I discovered the palliative team at Berry Hospital. So what does Richard do? He rings Berry Hospital now, you know, and rings around, and finally I get this person on the phone who says, oh yeah, no, I'm the administrator for the palliative team down here. So I shared with her Kai's story. And I said, I do not want this for Bodhi. How do we not have this happen for Bodhi? And she said, that is not going to happen when Bodhi comes down here. Here is the doctor's name, Dr. Steph. Here is the fax number that I'm looking at. And I said, you're not serious, are you? And she said, yeah, no, we still use faxes. So here's the fax number. She said, the minute your fax comes through with Bodhi's referral, I will ring you on your mobile phone to tell you I've got it. So what happens in Manly? And I said, look, can I give you, here's the post-it note, here's doctor. The doctor goes away, she comes back 45 minutes later and says, I've made the referral. I said, fantastic, because I didn't want the same thing to happen. I said, did you use the name and the fax number I gave you? No. Oh, why not? No, when I rang Wollongong, because Wollongong is the ones who actually have they're the ones who run Shoalhaven, because it's Illawarra and Shoalhaven, they told me it was this fax number and this was this doctor. And I was like, what? I said, could you humour me? Please humour me, right? Because, of course, this is an hour later. I didn't get any phone call. Could you humour me and just also send the same referral to that doctor and to that fax number? Oh, yeah, all right. 5 minutes later, I get the phone call. Just got your referral. Just wanted you to know. And I just said, this is what's just happened. How did that happen? Oh, that happens all the time. Because the doctors ring Wollongong. Wollongong don't know how it works. Illawarra doesn't know how it works in Shoalhaven. And you go, but it's the same health district. How can you not know? So to Jean's point, you cannot do enough research. And the wonderful thing was I said, oh, we're leaving today. How long until we get an appointment? Can we drop in on the way down? And she said, no, you don't need to do that. She'll be there first thing tomorrow morning. And that's what happened, is 9 o'clock the next day, Dr. Steph turned up and, oh my God, they'd got a warm handover, because it turned out they went to medical school together. The consultant at Aya and Dr. Steph, which was fantastic. So, but can I just say, yes, you cannot do enough research to find who you need to speak to, have their numbers for what scenario. Yeah.
And you can't make assumptions that because it is a hospice, they will know, or because they don't always know. And that's not because they don't want to know. They're just, like in our case, our kids were complicated. And even our wonderful local palliative care, Dr. Steph, she was like, I've given this kid all sorts of stuff. He should be unconscious, and yet he's talking to me. What on earth do I do? So we suggested, why don't you ring Aya, because they're used to complex kids, and so they then had other ideas, which in the end worked. We assume because they are palliative specialists, they know everything, but they don't always know everything. And it's another thing we learned. You just always have to ask the question, do you have this? Do you have that? because as lay people, we just think sometimes doctors know everything, but they're human beings and they don't. And it's we felt it was our job as parents to be on the front foot and make sure that, and we have checked. I have had discussions with my neurologist where I said, "You are wrong." And he was like, and he was wrong. And to his credit, admitted it later on. So you have to take that agency, you have to take control. There is just no other way, because you know your husband, you know your parents. You're the only one. The doctors just can't know all that. So you have to take control.
And I think, if I just might add to that, what Heike said, where she mentioned hospices, so find out all the alternative places that can help you at the end of life. All the alternatives, because a lot of communities have beautiful hospices. They've got hundreds of volunteers. They've got palliative care nurses, and they take people in, and they don't charge, as far as I know. A lot of these communities, and you've got to know where they are and how you access them too, if it's all too hard at home, because they're often like homes. So just get all the info. What's the time? Oh yeah, we probably have to wrap up, but I would love to hear just some final comments from you, Peter, and then Camilla. Have you got something? Yes.
I think Richard and Heike are intelligent, articulate, with good health literacy. They've had to learn the hard way. We have to look after the people that don't have that health literacy, that don't have that confidence, that don't have those searching skills, that don't have the internet. There are so many people that we need to look after who don't have that. You have taught me a lot, and that's one of the beauties of going to work every day. You learn something new every day. I learn by being with my patients. They teach me a lot. It's stuff that I'll take back and tell stories to my colleagues, and hopefully they sit and think and ponder. So thank you for sharing that. But we have to look after the marginalised, those that are disempowered, because they're getting left behind.
I think my last comments would be is, don't forget there's some incredible palliative care practitioners out there. There's some amazing people. There are many amazing services, but there's not enough of them. There's not going to be enough specialist palliative care to see all the complex patients of the future when we've quoted the stats of our ageing population. We need to think about and plan for how we're going to meet those needs, and we cannot rely on primary health only. We need to really plan for and think about what palliative care for everybody is going to look like in the future. And it's really important that as opportunities like voluntary assisted dying are introduced, that people all have the ability to access palliative care, whether they choose VAD or not, that option is always available. So there's a lot of work to be done. There's some great services, great health practitioners out there, but we need to build on that.
Thank you so much, Camilla. I mean, really, we are a team. We know that it takes a village to raise a child, and it also takes a village to make sure our loved ones reach safe harbour at the end of their lives. And that means we all have to work together, the health and care sector and the government and the civilians, families and friends. So I think that's come across really strongly, that we do all need to work together on this to just make it a better experience for everyone. If we come to an end, the time, of course, we've run out of time. And I know there's been a lot of, I don't know what that was, but yeah, subtle hint, yes. There's a lot of profound human emotions that have been discussed tonight. I hope it wasn't too distressing for any of you. It's a sort of gamut of human emotions that palliative care experts deal with every single day, but I hope you feel better for having thought about all these issues. And I know that if you could support Palliative Care Australia this coming week and, add to the groundswell of people asking the government to give us the community and the sector, the health and care sector, the resources they need to be able to make palliative care accessible for everyone. While the last 3 years of health and care reforms have taken us forward, the message for the new government is that better access to palliative care must be central to the next steps in our country's reform journey. All Australians, whoever they are and wherever they are, need access to palliative care. And next week, in National Palliative Care Week, is a perfect opportunity for us all to ask governments at state and federal level, what's your plan? Because we're getting our plans in place. What's your plan? We've done what you've asked. Now it's your turn to step up and have the hard conversations and make the right decisions. Thank you all so much for being part of tonight, and thank you for your advocacy and in this groundswell of change for supporting Palliative Care Australia. To help even further, please head to the Palliative Care Australia website to get more involved. Thank you, Palliative Care Australia, and our fantastic panellists. Thank you, Richard and Heike and Peter and Camilla. Thank you all so much, and thank you. Good night. Thank you.